My name is Michelle Hidalgo. Today, I'm going to talk about adjuvant sunitinib in high-risk renal cell carcinoma after nephrectomy. First, the definition. Sunitinib is a vascular endothelial growth factor pathway inhibitor. It's an effective treatment for metastatic renal cell carcinoma. Although the prognosis for patients with metastatic renal cell carcinoma has improved in the past decade, no curative treatment is currently available. Several adjuvant strategies, including cytokine therapy, radiotherapy, and hormone therapy, have been explored to decrease the rate of relapse, but none were successful.
I present a phase 3 study comparing an anti-angiogenic drug, sunitinib, compared to placebo in adjuvant setting after nephrectomy for high-risk patients' risk of recurrence. RCC is a relatively frequent tumor, more than 300,000 patients worldwide. And the problem as any tumor type that when you have been surgery, you may have risk of recurrence. It is known that you can achieve that in breast and colorectal.
Now, application in medicine. Renal cell carcinoma occurrence shows a male predominance over women. We have a classic trait here: hematuria, flank pain, and abdominal mass. Today, renal cell carcinoma is often asymptomatic, meaning few to no symptoms, and is generally detected incidentally when a person is being examined for other things. And we have pros and cons. When we talk about pros, among patients with local regional clear cell renal cell carcinoma, at high risk for tumor recurrence after nephrectomy, the median duration of disease-free survival was significantly longer in the sunitinib group.
Based Consortium prognostic score. Among 847 patients with intermediate or poor risk and a median follow-up of 25.2 months, those randomized to nivolumab plus ipilimumab had significantly improved overall survival, 75% versus 60% for sunitinib at 18 months, and a significantly improved objective response rate, 42% versus 27%. Progression-free survival was not significantly different between the groups because it did not meet the pre-specified threshold for multiplicity testing. Grade 3 or 4 treatment-related adverse events occurred less frequently with nivolumab plus ipilimumab than with sunitinib, 40.
Now the cons. Survival was significantly longer in the sunitinib group than in the placebo group, at the cost of a higher rate of toxic events.
Clinically, when we're thinking about who to treat with sunitinib, we want to pick the patients we think are most likely to benefit. By enriching for these highest risk patients, we can really focus even further on the patients most likely to benefit. So when I see a patient in my clinic who has node-positive disease, or a patient that has T4 disease, or really high-grade poor performance status disease, that's a patient I'm going to be more inclined to offer sunitinib to, even if I think maybe medically they might be a little bit on the fence. They might be a little bit older, or they might have other issues. Can they really tolerate sunitinib for a year? I don't know. That's a patient I still want to have the conversation with, because there's even a greater risk of them recurring, and there's even a greater benefit associated with that adjuvant therapy.
Now issued applied in Ecuador. In Ecuador, The most common carcinoma in the different subtypes of cancer is renal clear cell. Among the most important factors that acquire risk as snuff or overweight addition to hereditary predisposition.
The most compelling data are the S-TRAC study showing a disease-free survival advantage for sunitinib. We have to take those results with a grain of salt because there are other studies that do not.
And at the end, the conclusion. Among patients with locoregional clear cell carcinoma at high risk for tumor recurrence after nephrectomy, the median duration of disease-free survival was significantly longer in the sunitinib group than in the placebo group, at a cause of higher rate of toxic events. Thank you so much.